So history-wise, TB is one of the most oldest recognized diseases of mankind. In fact, India, Rigveda and Atharveda, back in the year 3500 to 1800 BC, and the Samhitas of Charaka and Sushruta, back in the year 1600 BC, had also defined and tried to describe this disease as Yakshma. So imagine back in the literature talking about years like 600 BC also, this disease was uh, prevalent. And even there is some evidence of that in the literature which is present, which is dating back to those centuries. Also in the Egyptian mummies, TB has been recognized. So again, as you are understanding, we are talking about not just in India, but in Egypt. So basically, this is one of the oldest diseases which might be prevalent globally since a very long period of time. Scientifically, when we come to the modern history, Percival Potts described the TB first in the spinal column in the year 1779. What he tried to describe at that time was there is a destruction of the disk space and the adjacent vertebral bodies. There is a collapse of the spinal element, which leads to a progressive deformity. So, if ever we think about tuberculosis, which is progressive, which is not getting control, so whatever definition was tried and given in the year 1779 somehow holds true, because tuberculosis does majorly originate in the paradiscal space and it impacts the vertebral body adjacent to them, and there is a collapse of the spinal element which finally lead to the deformity. So imagine back in the year 1779 when the first time it was tried to the description of TB in the spine was tried to be given, a lot of things were given at that time which are still true, I would say. Robert Koch first described Microbacterium tuberculosis in the year 1882. So this is not about TB in the spine overall. In general, he had discovered MTB in the year 1882. Epidemiology. So an estimated 10 million new TB cases worldwide were found. So this is the global tuberculosis report from the year 2019 given by WHO. So as per 2019, 10 million new cases were added. People living with HIV accounted for 8.6% of all the new TB cases. So, patients who are having concurrent HIV and TB were 8.6. That means that, all the cases who were getting TB, the new cases of tuberculosis that were being diagnosed, 8.6% of them had HIV as well. There is no sexual preponderance, that is like both the sexes are impacted equally. However, the highest burden of the disease is seen in men over the age group of 15 years, which is 57%, followed by that in women, 32%, and then in children who are aged less than 15 years, they account for 11% of the disease. So even though it won't impact there is no difference of male or females getting more impacted. However, definitely the burden is highest seen in men, followed by women, and then children. When we talk about drug resistant TB, because this drug resistant TB has been an issue since quite some time now, wherein normal TB medicines don't help, and we have to go in for injectables and other modified AKT. So in the year 2018, it was seen that 500,000 new cases of rifampicin resistant TB, of which 78% had multi-drug resistant TB. So imagine 500,000 new cases were of rifampicin resistant TB, and 78% of them had not just rifampicin resistance, but they were multi-drug resistance. The three countries that have the largest share of the global burden are India, 27%, China, 14%, and the Russian Federation, which is 9%. This is the reason why the government programs these days are aiming towards the eradication of tuberculosis, and a lot of programs are being aimed at proper management of the diseases with proper guidelines so that the drug resistance does not increase further, and also culminating the transmission and the disease altogether. What are the predisposing factors when it comes to tuberculosis? So, malnutrition, poor sanitation, overcrowding, close contact with a TB patient, immunodeficiency state. So these are the predisposing factors wherein, there is no proper nutrition, sanitation is not there properly, overcrowding is there, and this is the reason why this disease, it may not be wrong completely to say that it is more impacted wherever overcrowding is there, like in the area where slums are there, because the sanitation is also an issue, and also there is a lot of malnutrition. Any close contact with the TB patient, however, whenever we talk about spinal tuberculosis, so that is also the tuberculosis that most commonly goes from the lungs. We basically, the source that we get it from is someone who's carrying it in the lungs. So that infection from the lungs travels to the spine. And especially, this is more prevalent in the cases who are immunodeficient. So patients with immunodeficiency get impacted more easily. Mycobacterium, what are the types? So the most common is the tubercle bacilli, which is Mycobacterium tuberculosis. Apart from that, in that same family, there are some other bacteria also which may come. That is Mycobacterium bovis, avium, microti, marinum. Also, the lepra bacillus, that is Mycobacterium leprae, comes under the same umbrella. However, the families are different. Also, in the skin, Mycobacterium ulcerans and Mycobacterium bellni are something that may impact. There are atypical mycobacteria as well, like Mycobacterial scrofulcium and Mycobacterium canasi, Mycobacterium avium, and smegmatis. So these are all the atypical mycobacteria that also come in the same family. John's bacillus, that is paratuberculosis, and saprophytic bacillus like Mycobacterium fili and smegmatis. So these are all the different mycobacterium bacteria which are there, which belong to the family of Mycobacterium. Amongst them, tubercular bacilli is the one that is the most rampant, I would say, in India these days, that causes this infection. What is the morphology of this bacteria? This is an obligate aerobe. It is slender, straight, slightly curved bacillus. It is not motile, it is not encapsulated, and it does not form any spores. This particular bacteria is hydrophobic. It grows slowly, so the growth is very slow, and it is sensitive to the heat as well as to the UV light. So again, a non-motile bacteria, non-encapsulated, there is no capsule and it does not form any spores. It is hydrophobic, it grows very slowly, and it is sensitive to heat and to UV light. Acid-fast bacteria it is, and it resists decolorization with acidified organic solvents that are once stained. So that is the reason why it is Zn positive, or the Zeal-Nielsen stain is positive, which is the main agent that is used for identification of these organisms on microscopy. Along with Zn, or the Zeal-Nielsen stain, auramine rhodamine stain is the other stain that is used for the identification of this organism. So whenever we send samples, we send it for the acid fast or the Zn staining most commonly. What is a pathology? So the TB bacilli is phagocytosed by the mononuclear cell. So the organism is there. The phagocytosis happens by the mononuclear cell that try to mount the immune response against the bacteria. So this particular mononuclear cells then cause the epithelioid cell formation. There is Langerhans giant cell formation by fusion of the epithelioid cells. Lymphocytes form a ring around the lesion, and there is a tubercle formation. So initially, as you are seeing, this is a macrophage with the ingested bacillus. They keep on accumulating like this, and then they form the tubercle. The primary site of the infection most commonly is the lungs, lymph node of the mediastinum, mesentery, GI tract, genitourinary system, or any other viscera. So these are the most common sites from where the infection happens. So most common is the lungs, the lymph node of the mediastinum, mesentery, GI tract, genitourinary system, other viscera. However, the most common is lungs and it most commonly comes from lungs only. The spinal infection is always secondary, and it is caused by hematogenous dissemination of the bacillus from the primary focus. So it's not like spinal infection is primary, it is secondary. It basically comes after the infection from the lungs. How does it spread? It spreads via the hematogenous way, and there is a hematogenous dissemination of the bacillus from the primary focus and it goes to the spine. The arterial supply of the vertebra favors the subchondral bone involvement on either side of the disc, and hence the paradiscal involvement is the most common type. So since the subchondral bone on the either side has got, so this particular area is a subchondral bone, which is just on the either side of the infected disc. So the arterial supply over here is very much high, and it favors the growth of the bacillus, and that is the reason why this paradiscal involvement is the most common involvement, wherein the bone starts to get involved just near the disc space. So once the bones gets involved, it keeps on spreading. As you're seeing, two bones are involved over here. As two bones are involved, it is undergoing a collapse. Why is it a collapse? Because this pathological bone cannot sustain the normal biomechanics or when we are loading the spine. So this is a collapsed bone, and this collapsed bone, then the fragments go behind. So this is retropulsion of the fragments. These pathological bony fragments have a compression on the spinal cord, which is causing the pinching of the spinal cord, and that is when these patients develop the deficit. So it starts with the paradiscal involvement, gets the bones infected, the bones gets collapsed, which finally causes retropulsion and the compression of the spinal cord. Over the time, the deformed vertebrae heal and fuse nicely. This may further compress the nerve roots, causing the pain and the deficit. So, as time goes, this deformed bone would heal and fuse there and then, and this will further compress the nerve roots. Why? Because this is the disease of the chronic pathology, then this will keep on compressing the nerve roots, which would cause the pain and even deficit. Pathology of the TB paraplegia. So there are changes in the spinal cord if there is unrelieved compression. So this compression causes the loss of neurons and the white matter. And these loss of neurons and the white matter causes a loss of cells and fibers, replacement by gliosis, and neural fiber shows loss of myelin, which finally is evident on the MRI in the form of spinal cord edema or myelomalacia. So I'm repeating, there is a lot of compression which is there secondary to the tubercular pathology. Because of this compression, there is a loss of neurons and the white matter. As these neurons and the white matter are lost, so these lost cells and the fibers which are lost because of the compression, they get replaced by gliosis, and the neural fibers then show loss of myelin. And finally, this is seen as myelomalacia or spinal cord edema on the MRI. Extradural granuloma and tuberculoma, rarely a small tuberculoma of spinal cord or diffuse extradural granuloma may cause deficit without any radiological evidence of TB of the vertebrae. So what happens? Sometimes a small lesion occurs, which is a tuberculoma, or sometimes a very extradural granuloma, a diffusely formed extradural granuloma can cause a deficit. And this is called spinal tumor syndrome, wherein this particular lesion won't have any impact on the vertebrae. The vertebrae are looking completely fine. However, this is more or less like a space occupying lesion which is causing the compression, and this compression may cause the neuropathic signs, the pain, and the deficit. And this is characteristically called spinal tumor syndrome. So the focus of infection can be possibly from any sides. Most commonly, it is pulmonary, followed by that, it is abdomen. So as I told you, the infection can come to the vertebrae from any side. However, most common is pulmonary or the lungs, and second is the abdomen. What are the routes of infection? So the infection from the pulmonary or the abdominal source may spread via the hematogenous way, or the lymph node spread, or a direct spread. If it is happening via the hematogenous way, it is via the Bateson's plexus. Lymph node spread is via the lymph nodes getting involved. Direct spread is if ever the lower lobes of the lung is involved or the posterior aspect. So from there, the direct spread may happen to the spine. Infection begins in the cancellous area of the vertebral body, which may be central, anterior, epiphyseal in location, advances and destroys the cortex, intervertebral disc, and the adjacent vertebrae. So the infection most commonly begins in the cancellous area of the vertebral body. It may be central or anterior or epiphyseal. It advances and destroys the cortex, the disc spaces in between, and also the adjacent vertebrae. Infectious exudate may spread anteriorly beneath the anterior longitudinal ligament and the neighboring vertebrae. So all this infection which is there, this will begin spreading anteriorly just below the anterior longitudinal ligament, and that is how it goes and spreads to the other vertebrae also. So this is how the spread may involve a lot of vertebrae, and also skip lesions may be involved like that, because sometimes when we do whole spine screening, we see there are even 3 or 4 focuses of infection. Regional distribution of TB spine. So where and how and which are the areas that are most prone to development of the tuberculosis of the spine. So the most common area for the development of TB spine is the dorsal spine. 42% of the cases have the impact on the dorsal spine. Followed by dorsal spine is the lumbar spine. 26% of the cases have infection in the lumbar spine. 12% cases have got infection in cervical and the dorsolumbar spine. 5% of the cases have junctional involvement at cervicodorsal, and 3% have got involvement at the lumbosacral area. So the most common is dorsal, and junctional wise, dorsolumbar is more common as compared to cervicodorsal. Why am I focusing on this? Because this was asked as the MCQ. Which of the statements is false? In which it was said junctional cervicodorsal TB is most common as compared to dorsolumbar. So that was wrong, because dorsolumbar is more common as compared to cervicodorsal. So dorsal is 42% cases, lumbar is 26, cervical and dorsolumbar is 12, cervicodorsal is 5, and lumbosacral is 3%. What are the different types of the vertebral lesions? So depending on where and how the spread has happened, the infection may end up at different areas of the spine. So when we talk about the paradiscal lesion or the infection, that is the arterial spread. Arterial spread would happen via the arterial source or via the arterial blood vessel, and it involves the paradiscal space. Central areas are involved whenever there is a spread via the venous way or via the Bateson's plexus. Anteriorly, subperiosteally, the spread may happen, which is generally, when the collection happens just below the ALL. Appendicular or articular are a bit rare type of lesion. We do incur that, but the chances are bleak. Most common is paradiscal, and basically whenever there is a paradiscal involvement, that means the spread has happened via the arterial source. Whenever it is central, it is via the venous way, and whenever it is anterior, it is a subperiosteal spread. What are the features in the active lesion? So there are some constitutional symptoms. What are these constitutional symptoms? Malaise, loss of weight or appetite, night sweats, evening rise of temperature. So whenever the lesion is active and it is growing, patients would complain to you of some lethargy, malaise. The patient would say that we have been experiencing loss of weight since the past couple of months. Also, there is a loss of appetite. These patients also have night sweats, and also they complain of evening rise of temperature. They would feel they are striking temperature in the evening of fever. Specific symptoms: pain or night cries, stiffness, deformity, restricted range of motion, enlarged lymph nodes, abscess, and neurodeficit. So these are the specific symptoms which we would see in the active disease, wherein the patient, because of the relaxation of muscles as the bones go and collide with each other, they would complain of pain that increases in the night, which may also be associated with night cries. There would be a lot of stiffness of back. The patients may also have deformity. The range of motion is restricted. The lymph nodes would be enlarged. There would be abscesses and neurodeficit. So these are all the features of the active lesion. What about the healed lesion? So the patient, since the lesion is healed, constitutional symptoms won't be there. Malaise, loss of weight, appetite, night sweats, evening rise of temperature. So these things you are not going to witness in these patients who are having healed lesion, because a lesion is healed, there won't be any constitutional symptoms. Along with this, the specific symptoms, pain and night cries again won't be there because the lesion is healed. So, since the lesion is healed, even when the muscles relax, the bones are not going to go and collide with each other because they are already healed, maybe in a normal or acceptable or unacceptable position. Along with that, enlarged lymph nodes. Since the disease is not active, the lymph nodes won't be reactive, and there won't be any abscess. There won't be any liquid abscess or pus because the lesion again is healed. However, when we talk about the healed lesions, still the patients are going to have stiffness. They are going to have deformity. The range of motion is going to be restricted, and these patients also are going to have neuro deficit. So remember, my friends, the features of healed lesion are going to be stiffness, deformity, restricted range of motion, and neuro deficit. So these are all the features in a healed lesion which is not active. Upper cervical TB. So upper cervical TB is there in 1% of the cases of overall over spine tuberculosis. Most commonly, it is seen in children who are less than 8 years of age. What is the mode of spread? So cervical lymph nodes, from there to the retropharyngeal tissues, osseous elements and ligaments. So this is how the spread happens. So from the cervical lymph nodes, it will involve the retropharyngeal tissues and then the bony structures and the ligaments. Sometimes this may be associated with atlantoaxial instability, which is the instability because of the bones. Why the instability happens? Because of the destruction of transverse and alar ligaments, which causes the medullary compression. So atlantoaxial instability or C1, C2 instability happens because the infection destroys the transverse and the alar ligaments. These ligaments are destroyed, and subsequently there is a medullary compression that happens. There are three stages that were given by Lefixo on the X-ray. The stage 1 shows no evidence of any bony involvement, and stage 2 and 3 are a progressive stage of destruction and instability. So upper cervical spine TB is not common. In less than 1% of the cases we see it. Most commonly would be seen in children less than 8 years of age. The spread would be via the cervical lymph nodes, retropharyngeal tissues, and then from there to the osseous elements and the ligaments. Rare but atlantoaxial instability can occur, which is secondary to the destruction of the transverse and alar ligaments, and subsequently it causes the medullary compression. There are three stages given by Lifso on the X-ray. No evidence of bone involvement is stage 1, 2, and 3 are progressive destruction and the instability. The patients complain of severe neck pain and restricted range of motion. They would also complain of torticollis. The neck would be bent on one of the sides. They would be complaining of dysphagia, difficulty, to eat, and also dysphonia. And why does this dysphonia happen? There is a challenge in talking, and the speech and the volume is not there. So this happens because of retropharyngeal abscess. So whenever there is retropharyngeal abscess, the patients are also going to have dysphonia. In some cases, reports, it is also shown that sudden death happens due to cervicomedullary compression. So whenever pus would compress the cervicomedullary junction, the patients may also succumb suddenly. Whenever there is an associated cranial nerve involvement, so with the associated cranial nerve involvement, the patients may develop hemiplegia, monoplegia. Why will it happen? Due to vertebral or lower basilar artery thrombosis. So whenever there is a cranial nerve involvement, the patients would also complain of associated hemiplegias and monoplegias, which are most commonly due to the thrombosis of the vertebral or the basilar arteries. cervical spine TB in the skeletally immature patients. So diffuse involvement is generally seen. Large abscesses form which cause a respiratory obstruction. Sinus formation is rare because the prevertebral fascia is thick. Kyphotic deformity after healing generally is seen, and the chances of developing kyphotic deformity and the intensity of the deformity are greater than when it happens in mature age group. Why is it so? Because whenever it happens in this age group, the deformity is also more, and with the growth the deformity keeps on increasing, which is not so in the cases who are skeletally mature.